Good morning, everyone. I'm excited to welcome you to today's presentation. We'll be exploring bronchiolitis, recognition, assessment, and management. This is a comprehensive clinical guide designed to help you manage this common and sometimes challenging viral inflammatory illness of the small airways in children. Over the course of this session, we'll cover how to identify the condition, assess severity, and implement effective management strategies. I look forward to sharing valuable insights with you, so let's get started. Understanding bronchiolitis is crucial because it's a common illness we see, especially in young children. So, let's start with what it actually is. Bronchiolitis is an acute viral inflammatory illness that affects the small airways in the lungs. When I say small airways, I mean the bronchioles, which are the tiniest branches of the airway tree. This condition usually happens during winter epidemics, which is when many respiratory viruses tend to circulate the most. Primarily, bronchiolitis affects children under the age of 2. This is a vulnerable age group because their immune systems are still developing, and their airways are smaller and more sensitive. The main problem here is inflammation and mucus buildup in the bronchioles. When these tiny airways become inflamed and filled with mucus, it makes it harder for the child to breathe properly. This is why understanding bronchiolitis is so important. It's a common cause of respiratory distress in young children, and recognizing it early can help us manage symptoms effectively and prevent complications. So, in essence, bronchiolitis is a viral infection that causes inflammation and mucus in the small airways, leading to breathing difficulties, especially during those cold winter months. Let's go through some of the key clinical features we often see. First, fever. Usually the temperature is less than 38.5 degrees Celsius, so it's not always a high fever, but it's still an important sign to monitor. Next, respiratory distress is common, and you'll notice it through progressive tachypnea, which is faster breathing, along with nasal flaring and intercostal recession. Those are signs that the child is working harder to breathe. We also need to be vigilant about the risk of apnea, which means episodes where the child temporarily stops breathing or hypoventilation, so close monitoring is essential in these cases. Lastly, on chest examination, you'll often find a hyperinflated chest, which indicates air trapping, and auscultation may reveal widespread fine crackles and wheeze. All of these features are interconnected and help us understand the severity and nature of the respiratory condition we're dealing with. Recognizing these signs early is crucial for effective management and improving outcomes for our young patients. When evaluating a young child with respiratory symptoms, it's really important to differentiate bronchiolitis from other conditions that can look similar. For example, recurrent viral-induced wheeze is common. These are episodes where wheezing occurs repeatedly, often triggered by viral infections. Recognizing this pattern helps us understand that the underlying cause is often related to viral triggers leading to airway narrowing. Early asthma is another consideration. It involves chronic airway inflammation, but what's key here is that the obstruction is typically reversible with treatment. So, if we see signs of persistent wheezing that improve with medication, asthma might be the culprit. Cystic fibrosis is a genetic disorder that affects mucus production and clearance, leading to thick, sticky mucus that can clog airways. It often presents with recurrent lung infections and failure to thrive, so keeping this in mind is crucial, especially in children with a family history. Pertussis, or whooping cough, is characterized by a distinctive paroxysmal cough that can be quite severe. Recognizing this pattern is vital because it requires specific treatment and has public health implications. Recurrent aspiration occurs when food or liquids are repeatedly inhaled into the airways. This can cause persistent coughing and respiratory infections, and it's often related to swallowing or swallowing coordination issues. Lastly, foreign bodies or congenital anomalies are structural or obstructive causes that need different management strategies. A foreign body in the airway can cause sudden onset of symptoms, and congenital anomalies may present with ongoing issues that need surgical or specialized intervention. All these conditions highlight how diverse respiratory presentations can be in children, making careful assessment and differential diagnosis essential in guiding effective treatment. Let's start with the essentials of investigations. First, routine assessment is key. Monitoring SpO2 while the patient is breathing room air is absolutely crucial for all patients, regardless of how mild or severe their condition seems. It gives us a quick, reliable indicator of their oxygenation status. It's also important to avoid unnecessary tests that won't impact immediate management decisions. We want to be efficient and avoid overloading the patient with unnecessary procedures. Now, when it comes to capillary blood gas analysis, there are specific indications. For example, if the respiratory rate exceeds 80 breaths per minute, that's a sign of severe distress and warrants further investigation. Similarly, if the transcutaneous PCO2 is above 6 kPa, that indicates hypoventilation or CO2 retention. We should also consider capillary blood gases if SpO2 drops below 92%, while on more than 50% inspired oxygen, which suggests significant hypoxemia. Finally, severe respiratory distress itself is an indication. We want to assess the patient's ventilation and gas exchange closely in these cases. So, in summary, these targeted investigations help us identify the severity of respiratory compromise and guide our management effectively. All right, let's look at some specific testing indications. First up, the viral nose swab for PCR. We typically recommend this when flu prevalence is high, especially if the patient requires admission. In such cases, prescribing oseltamivir can be very effective. It's also important in severely immunocompromised patients, where identifying the virus quickly can really guide management. Additionally, local cohorting guidelines may suggest testing, so always be aware of those. Next, we have the chest X-ray. This is indicated if there are localizing signs, such as chest pain or abnormal breath sounds, or if a cardiac murmur is detected, which could point to underlying cardiac issues or other complications. Finally, U&E and blood cultures. U&E tests are useful if you're planning to give IV fluids to monitor kidney function and electrolyte balance. Blood cultures should be taken if there's evidence of sepsis or if the patient's temperature exceeds 38.5 degrees Celsius. These tests help us identify the source of infection and guide targeted therapy. So, in summary, these are targeted tests based on clinical signs and patient status, aiming to guide effective and timely management. Let's go through the immediate treatment priorities to ensure the best care. First, infection control is crucial. When a patient has a contagious condition, placing the nurse in the same cubicle or bay as other patients with the same diagnosis helps contain the infection. And of course, strict hand washing is essential to prevent the spread of germs. Next, positioning plays a vital role. Elevating the patient's head helps reduce splinting of the diaphragm, which means the diaphragm can move more freely. This position also helps improve breathing mechanics, making it easier for the patient to breathe effectively. Finally, airway clearance is a key step. Carefully suctioning the nares and mouth can help clear the airway. Before suctioning, using sodium chloride 0.9% nose drops can loosen secretions and make the process safer and more comfortable. All of these priorities are interconnected. They work together to stabilize the patient quickly and support their recovery. Let's talk about oxygen therapy guidelines. Appropriate oxygen delivery is absolutely essential when managing hypoxemia in patients with bronchiolitis. Getting this right can make a big difference in patient outcomes. First, let's consider the initial assessment. If a child's oxygen saturation, or SpO2, is 90% or less while breathing room air, that's a clear sign we need to intervene. Similarly, for children under 3 months or those with other health conditions, an SpO2 below 92% warrants attention. This helps us identify who's at greater risk and needs prompt oxygen therapy. Now, regarding oxygen delivery methods, the main options are a face mask with a reservoir bag or nasal prongs. For nasal prongs, we typically deliver 1 liter per minute in children under 5 kilograms and 2 liters per minute for those over 5 kilograms. These settings ensure adequate oxygenation without causing discomfort or excessive oxygen flow. Humidification is another important aspect. Whenever possible, we should use heated humidified oxygen. This helps prevent dryness and irritation of the airway, especially with higher flow rates or prolonged use. Overall, the goal is to deliver oxygen safely and effectively, tailored to each child's needs, to ensure they get enough oxygen and recover more comfortably. Now, let's discuss the critical warning signs that indicate impending respiratory failure. One key indicator is an SpO2 level below 90%, especially if this occurs while the patient is on more than 50% oxygen or receiving just 2 liters per minute of oxygen through nasal prongs. Additionally, if the patient experiences cyanotic episodes despite supplemental oxygen, that's a serious red flag. Monitoring is essential here. We need to review the patient's oxygen saturation levels hourly and keep a close eye on any signs of deterioration. Early detection is vital to prevent progression. When intervention is necessary, humidified high-flow nasal cannula oxygen can be very effective. We typically start at around 2 liters per kilogram per minute, with a maximum flow rate of 20 liters per minute. This approach helps improve oxygenation and reduces the work of breathing, giving us a better chance to stabilize the patient before more invasive measures are required. Remember, timely recognition and intervention are crucial in managing respiratory failure effectively. So when should we consider escalating to CPAP? Well, one key sign is abnormal breathing patterns, such as tachypnea, which is rapid breathing, or bradypnea, which is unusually slow breathing. Both can be indicators that the patient is struggling to maintain adequate ventilation. Another important point is the presence of severe respiratory recession. You'll notice this as significant intercostal recession, where the muscles between the ribs sink in during inhalation, showing that the patient is working very hard to breathe. This increased effort can quickly lead to fatigue and deterioration. We also need to watch for rising levels of carbon dioxide, specifically if the PaCO2 increases more than 3 kPa from their baseline. This suggests that ventilation isn't keeping up with the body's needs, indicating ventilatory failure. Lastly, if the patient develops respiratory acidosis, with a pH dropping below 7.2, that's a clear sign that their lungs are failing to remove enough CO2, leading to acid buildup. All these signs, abnormal breathing, increased work of breathing, rising CO2, and acidemia, are critical indicators that it's time to escalate to CPAP to support the patient's breathing more effectively. Recognizing these early can make a significant difference in outcomes. Let's now discuss the fluid management strategy. First, we prioritize oral feeding whenever possible. Encouraging the patient to take fluids and feed orally helps maintain hydration and supports recovery. It's always best to promote this approach unless contraindicated. However, if oral feeding isn't tolerated and the patient still has normal airway protective reflexes, then a nasogastric tube becomes the next step. This allows us to continue providing nutrition and fluids safely, even when oral intake isn't feasible. In cases where the patient's respiratory rate exceeds 80 breaths per minute persistently, or if we observe deterioration in their respiratory status despite NG feeding, we need to reassess our approach. Under such circumstances, switching to intravenous fluids is essential. We typically administer fluids like fluid DNS with potassium chloride at about 80% of the maintenance requirement to carefully support hydration without overloading the patient. Overall, the key is to tailor fluid management to the patient's respiratory status and tolerance, ensuring adequate hydration while minimizing risks. Let's talk about antibiotic considerations in bronchiolitis. The general principle here is that antibiotics are not routinely indicated because bronchiolitis is a viral illness. This means that giving antibiotics without a clear bacterial infection isn't usually helpful and can contribute to resistance. However, there are specific situations where antibiotics might be considered. For example, if there is consolidation seen on a chest X-ray that could suggest a bacterial pneumonia, and antibiotics might then be appropriate. Another indication is persistent fever greater than 39 degrees Celsius. But in such cases, it's important to discuss this with a consultant to determine whether antibiotics are truly needed. Lastly, if there are clinical signs pointing toward a bacterial superinfection, such as worsening symptoms or new findings, then antibiotics may also be justified. Overall, it's crucial to differentiate viral from bacterial infections carefully and to avoid unnecessary antibiotic use, aligning with good antimicrobial stewardship principles. Let's talk about monitoring during admission. First, vital signs are crucial. We need to continuously monitor heart rate, respiratory rate, and oxygen saturation. This helps us detect any early signs of deterioration, so we can act promptly. Next is feeding assessment. It's important to regularly evaluate how well the baby tolerates feeding and to check hydration status. This ensures they're getting enough nutrition and staying hydrated. Finally, clinical review plays a key role. We need frequent reassessment of respiratory effort and the overall clinical condition. Keeping a close eye on these aspects allows us to respond quickly to any changes and provides the best care for our patients. This continuous monitoring supports the overarching goal of ensuring safety and stability during admission. All right, let's talk about discharge criteria. Patients can be safely discharged when certain key points are met. First, oxygen saturation is crucial. We want to see a SpO2 of 90% or higher in room air consistently. This indicates that their lungs are functioning well enough without supplemental oxygen. Next, feeding is important. Patients should be fully fed orally, ensuring they can take in enough nutrition on their own. Lastly, family confidence plays a vital role. The family needs to be educated and confident in caring for the patient at home. When all these criteria are satisfied, it's a good sign that the patient is ready to go home safely and comfortably. These points tie back to our overall goal of ensuring safe, effective, and confident discharge planning. Now, let's talk about some red flag symptoms that families should be aware of. These warning signs indicate that a baby might need immediate medical attention, so it's important to recognize them early. First, apnea refers to pauses in breathing or even stopping breathing altogether. If you notice your baby holding their breath, or if their breathing seems irregular, this is a serious sign. Next, cyanosis is when the lips or skin turn a bluish color. This can happen when there's not enough oxygen in the blood, and it's definitely a sign that urgent care is needed. Poor feeding is another key indicator. If your baby is taking less than 50% of their usual feeds, or if they haven't had a wet nappy for more than 12 hours, it suggests they might be struggling and need medical evaluation. Exhaustion is also critical. If your baby is extremely tired or having difficulty staying awake, this could be a sign of worsening health. Finally, worsening breathing, such as increased effort to breathe or signs of respiratory distress, should never be ignored. If you see these signs, seek help immediately. Remember, these symptoms are warning signs that something serious might be happening, so quick action can make a real difference in your baby's health and safety. Let's talk about prevention and education, which are key components in protecting our communities from respiratory illnesses. First, addressing smoke exposure. It's crucial to avoid passive smoking, especially in households. Secondhand smoke can significantly increase the risk of respiratory infections, so creating smoke-free environments helps safeguard vulnerable populations. Next, I want to highlight the RSV vaccination program. Educating families about this vaccine is vital, particularly for pregnant women over 28 weeks and elderly individuals over 75 years old. These groups are more vulnerable, and vaccination can provide critical protection for both mothers and seniors. Overall, these strategies, reducing smoke exposure and promoting vaccination, are essential steps in our broader effort to prevent illness and promote health through education. Let's talk about hospital follow-up indications. First, for PICU ventilation, any patient who required ventilation in the PICU should have a follow-up to assess their recovery progress. It's essential to monitor how well they're healing and to ensure there are no lingering issues. Next, when we see consolidation on a chest X-ray, we shouldn't automatically assume it's normal. Instead, we need to perform a clinical reassessment to understand what's happening. Routine follow-up X-rays are not always necessary unless the clinical exam shows abnormalities. That's a key point to remember. Finally, for ex-preterm infants with chronic lung disease, these children require specialized follow-up care. Their condition can be complex, and ongoing monitoring is crucial to manage their lung health effectively. Overall, these follow-up strategies help us ensure we're providing targeted, appropriate care tailored to each child's needs, which is at the heart of what we do in pediatric respiratory management. Now, let's focus on some key takeaways for clinicians that will help us provide the best care possible. First, early recognition is absolutely critical. We need to identify signs of respiratory distress as soon as they appear and monitor our patients closely for any signs of deterioration. Catching these early can make a huge difference in outcomes. Next, supportive care should be our primary focus. This includes ensuring adequate oxygen therapy, maintaining proper hydration, and facilitating airway clearance. These interventions are fundamental in stabilizing the patient and preventing further complications. Timely escalation is also vital. Knowing when to escalate care and transfer a patient to the PICU for more advanced respiratory support can be life-saving. It's about recognizing when the situation exceeds what can be managed at the current level of care. Finally, family education plays a crucial role. We need to make sure families understand the warning signs, the red flags, and know prevention strategies before they go home. Empowering families with this knowledge helps them be active partners in their child's care and can prevent emergency situations down the line. All of these points tie back to our overall goal: providing prompt, effective, and compassionate care to improve our young patients' outcomes. Remember, when it comes to bronchiolitis, it's mainly a viral illness that we manage supportively. That means focusing on keeping the child comfortable, ensuring proper hydration, and monitoring their breathing. It's important to avoid unnecessary investigations or interventions that don't really change how we treat the patient in the immediate term. For example, routine chest X-rays or unnecessary antibiotics generally aren't helpful and can even cause more harm than good. The key is to recognize when supportive care is enough and to prevent unnecessary procedures that don't contribute to the child's recovery. Keeping this approach in mind helps us provide effective, focused care that aligns with the overall goal of supporting the child's natural healing process.